It's really great. Oh, I tried to like it, but I was, I don't like it. No, that's crazy. Yes. I thought it like.
Okay.
We good?
Also, please follow the poll for something.
Actually, I can take this off, right?
Yes, you can
I'm
take
far
that
enough
off.
away.
Hey, Whitney, don't forget to record it, sweet pea.
I'm recording right now.
You're the best.
Oh, wow. All right, guys. I think we're up and running. Can everybody hear me? Can you people in Zoom land hear me? Wave, Dalton.
We can hear you.
All right.
Everybody sing happy birthday to Dr.
No.
Holloman.
There's no flying under the radar screen around here. So this talk is near and dear to my heart and something that is incredibly common and that you're going to be seeing. And what I did with this was I kind of merged two talks. I merged a former resident talk on hypertension with a talk updated by the new guidelines that just came out in 2017. And if you have not yet read that 72-page document, don't worry. You'll get the Cliff's Notes version today. So, all right, interrupt me if you have questions, but what we're going to do today is use the new practice guidelines and go over how we define and stage hypertension in children, who should be screened and how often, the most common causes by age, what do we do with them, how do we work them up, and it's kind of minimalist anymore, which is a good thing. And I want to empower you guys to be comfortable treating kids in your clinic with hypertension as much as you can be anymore. As you'll see, pediatric hypertension is no longer a nephrology problem, it's a primary care problem. So not that everybody's comfortable with it. I want to talk a little bit at the end about the drugs we use and also ambulatory blood pressure monitoring, so you're aware that we have a great tool for that assessment here. Again, this is the document, came out in 2017 in Pediatrics, and lead author is Joseph Flynn, who's head of peds nephrology at Seattle Children's Hospital, and has kind of been a national and international hypertension expert. What this did was updated the old guidelines, and that goes back to 2004, which was the fourth time those guidelines had been updated, the report on blood pressure in children. And this was a big committee. It was endorsed by the American Heart Association. Again, 72 pages, 30 key action statements, 27 additional recommendations. It's kind of overwhelming, but 8 significant changes. So we'll come it down to that because that's really what you need to know. And what were those? I guess they just didn't like words. You know, every time a committee gets together on a guideline, they like to change the words around to confuse people. So we don't use pre-hypertension any longer. It's called elevated blood pressure. So elevated blood pressure does not mean hypertension. And the rationale behind that, frankly, I'm not entirely sure. There are new normative charts for kids, and the difference here is they only use normal weight kids. So in the past, obese children had been included in the population-based norms for hypertension, and what that did was that skewed the normal to the right of the bell curve, right? Because blood pressure is relative to your weight. So the main change with the new tables, and you've probably seen these and they're in chalk and probably in every pediatric office, is what defines high for age is now a little bit lower than it was before. So we're realizing the prevalence might be higher than we once thought. There's a simplified screening table that I'll show you for nursing staff, a simplified classification for adolescents. The word simplified is awesome. There's a little bit more of a limited screening recommendation, so that went the other way. And then our evaluation and management strategies are a little bit more streamlined. I'll tell you, in pediatric nephrology practice, we had already streamlined this with the awareness that most of what we're seeing is essential hypertension. An expanded role for ambulatory blood pressure monitoring, and I'll show you that. And then some revised recommendations on echocardiography that I think are important for you. So some epidemiology, OL hypertension is very common, and estimated prevalence now in kids is between 3 and 4%. And if you look at those with elevated pressure short of hypertension, you can double that prevalence. And that's an important number because those kids go on to have hypertension either later in childhood or into adulthood. More common in minority populations, a slight male predominance. Of course, as you know, it's relative to your BMI. And for the last several years, the far and away #1 cause of hypertension in kids is essential hypertension, not secondary hypertension. Certain populations might have an increased prevalence and therefore warrant earlier screening, and that would be our overweight and obese population. Any kid that has obstructive sleep apnea or other disordered sleep has a higher incidence of developing hypertension. In our world, chronic kidney disease, very common as you see the number there. And anybody that has had preterm birth or was low birth weight is at higher risk for the development of hypertension. So small premature babies become overweight and obese adolescents with hypertension very commonly. The risk factors are multifactorial. You guys know this. It's an interplay of a lot of environmental and genetic issues that all come together to create this milieu of supporting elevated blood pressure. Family history is real important here, diet, all the things that you counsel patients on regularly on a daily basis. So why do we screen? Well, this is adult data, but it's impressive, and you're probably aware hypertension is the most common primary diagnosis in the US and costs our country billions in healthcare dollars. Elevated blood pressure in adults causes cardiovascular disease, stroke, and chronic kidney disease. And it's important to remember that we are now, as pediatricians, the gatekeepers of cardiovascular disease. So that begins very early on. Lot of premature deaths worldwide. And again, it's the highest risk factor for cardiovascular disease, more than smoking. So big problem in the adult world. And all of that has its origins in kids. And so we have a great opportunity to impact adult morbidity and mortality, as frustrating as it is at times, as you know already. So why is screening important otherwise? We know blood pressures in childhood track into adulthood. And so elevated pressure in a child predicts strongly the development of hypertension as an adult. And even a blood pressure in that 90th percentile or elevated range is a greater than twofold increase in the chance of developing hypertension as an adult. A lot of studies have looked at the origin of cardiovascular disease in kids now, and kids can actually develop carotid abnormalities and endothelial dysfunction and things that predispose to atherosclerosis. So, you know, and when I trained, you could put your blinders on regarding that adult problem. We didn't have to deal with that in kids, but now we do. And again, that can shape outcomes, so it's very important. Screening has been endorsed by a number of reputable entities. And you might be saying, well, yeah, duh, I see that that's important. But what I took out of this talk, because it's already long, is that there's actually some entities or groups out there that advocate not screening. And so I don't even want to put that up here because blood pressure screening is really important. So who should be screened? And this has changed a little bit. This is simplified. So we start routine screening of blood pressures at the age of 3. So pediatric practices need to be prepared to have cuffs small enough to be able to measure blood pressures in toddlers. And it's recommended that everybody 3 and above have an annual blood pressure check. It used to be recommended at all office visits, so they've backed off on that a little bit. If you're a high-risk patient, defined as you see there by obesity, kidney disease, diabetes, coarc, or any other risk factor, any other disease or medication known to elevate blood pressure, then every office visit should have a blood pressure check. The preferred method is the old-fashioned kind, the old manual blood pressure assessment, the auscultatory method. That is far more accurate than Dynamaps and other machines, which we use on a day in and day out basis, and we'll talk a little bit more about that. So it's recommended if that initial blood pressure is at or above the 90th percentile, that 2 additional readings be taken and averaged. I will tell you in clinical practice, because of the fact it's very easy to artificially create hypertension in an anxious kid and practically impossible to Zen meditate a high blood pressure down to normal. We don't average, we go with the best reading that we get, but we do take multiple readings. And those of you who have and will work with us in our clinic on nephrology, you'll become very facile in checking manual blood pressure. So why would we start screening before the age of 3, which is actually quite difficult for many practices? If you have a history of prematurity, low birth weight, any congenital heart, renal, or urologic disease, a history of recurrent UTIs, obviously a transplant patient we're seeing pretty frequently, but other malignancies. If you have a systemic disease or on drugs known to elevate your blood pressure, then obviously you should start screening earlier. But the general recommendation is 3. So the first key action statement that came out of this was that all kids 3 and above have an annual blood pressure, and that kids should have a blood pressure checked at all office visits if they are overweight or obese, have diabetes, kidney disease, history of coarctation, or are on medications that can affect their pressure. So this is the biggest bugaboo to the entire thing, right? How do I get accurate readings on anxious or hyper kids in a busy office practice? And look at this list, right? The cuff size is critical. We're going to really beat that dead horse today. But you should be cooperative and comfortable. Almost never happens, particularly in younger kids. You should be at rest for 3 to 5 minutes before you even have a blood pressure check. Now, if you have 50 kids to see, how on earth is this going to happen, right? Clothing out of the way, right arm only. Okay, so it's very common to switch from right arm to left arm, but I'll tell you all pediatric norms are based on right arm pressures. So to be consistent, there is no reason, unless you have awkward pulses or suspect some weird coarctation, no reason to take that cuff off the right arm. So nurses tend to do that instinctively. They want to compare, and we really don't know what to make of a left arm pressure that might be a little higher than the right in an otherwise normal kid. Back supported, feet on the floor, at least 2 readings. So this is really time consuming. In our office, where we're seeing maybe 8 to 10 kids in a half day, we can do this quite easily. But in a busy pediatric practice, that's obviously difficult. There are technical issues. Again, the cuff size comes up here. Most people do not keep their blood pressure devices calibrated and kept in that way, and they can lose their accuracy over time. The manual or auscultatory blood pressure is still the gold standard, and you remember the Korotkov sounds, right? So the basic thing is the first sound is systolic, and then when it disappears, that's K5, that's diastolic. The oscillometric devices like Dynamaps, a lot of people don't realize this, but not only are they not kept up very well, they have proprietary algorithms in them that calculate the pressure. It's not a direct measurement like your ears, and that information the companies won't release. So we really don't know how a Dynamap or an Omron or any of these other devices create the numbers on the screen after you push the button. And, you know, kind of interesting to me, there's observer bias. There's been some studies that show that nurses favor even numbers over odd, that nurses, if they look back at what the last pressure was, they're a much greater likelihood of hearing it at the same pressure at the follow-up visit. So you just get so used to doing this over and over again, you kind of, you know, you have to be mindful of that as well. So there are guidelines for bladder size within the blood pressure cuffs. And what I generally say, if you want to commit this to memory, great. But if you can lay your stethoscope on the olecranon fossa, the cuff is not too big. And you, again, are not going to hide high blood pressure with a big cuff, but you're certainly going to artificially create it with a small cuff. So this is a big problem because a lot of practices don't have thigh cuffs. And we get a lot of referrals for hypertension in big obese kids with BMIs in the 40s and 50s, and they actually have normal blood pressure when they see us. So again, it's having that range of cuff sizes that you can get that accurate reading on everybody. So the next key action statement is oscillometric devices can be used for screening. They're convenient, they're easy, particularly in little kids. If they're normal, you're okay. But an abnormal pressure on one of those should be confirmed with a manual blood pressure check always. And there's a website people can go and check and see if their device has been validated for use in pediatric patients. Dynamaps certainly have been around forever. All right, so how do we define hypertension? Well, how the adult world defines hypertension is the blood pressure that gives you morbidity and mortality. And that's kind of that one size fits all. It's moved a little bit because they're recognizing that they need lower blood pressures in the adult world to prevent cardiovascular disease. Well, we don't see that in kids. So we're left with having to deal with population-based data. That's the task force data. That's hundreds of thousands of children systematically, right arm blood pressures, generate a bell curve and establish the 95th percentile as abnormal. And that may seem flawed, but it actually works pretty well. And so the definition also depends on how you're measuring it. And again, you want to, talk about the ambulatory blood pressure monitor here in a minute. Huge variation, right? This is what people who don't like pediatrics get frustrated with. All of you love it, right? But we have a big variation. And so we have to go to those tables and look at the age and the sex and the height. And there are apps that shortcut that for you. And then the new task force, or the new guideline, as you see, stops that madness at 13, which is nice. Now one size fits all when you hit adolescence. And we use that data to determine what's abnormal. So here's the latest definition. So in kids age 1 to 12, normal blood pressure would be under the 90th percentile. Elevated would be at the 90th and up to just below the 95th. Stage 1 hypertension, I've hit the 95th, but I'm under stage 2. And stage 2 hypertension is the 95th plus 12. Okay. Now in 13 years and above, we got less than 120/80 is normal. And then if you get up into the 120s over 70s, you're in the elevated range. Hypertension stage 1 is now 130/80 for all adolescents. And stage 2, 140/90. And these are more, that's more the adult kind of guideline now. It simplifies things. So again, elevated blood pressure, that term has replaced pre-hypertension. So if you have an adolescent patient in the 120s over upper 70s, they are elevated. Why is that important? They're going to have hypertension. And so it's important to go ahead and implement lifestyle changes early on and prevent that from happening, or at least postpone it. It is recommended that they be followed a little more closely than just your annual well child care. So they should come back in 6 months so you can check in with them again and see how non-compliant they are with the lifestyle changes that you've reviewed with them, and what their blood pressure is doing. The new guideline suggests that if the blood pressure is still in the elevated range, they should get ambulatory blood pressure monitoring. Not quite sure about that, but we have it available if you ever want us to do that on a patient. And then they are indeed at risk. So really follow up. Most of the time with blood pressure, you can make a clinical decision. And if you're unsure and know you can get them back in 1, 2, 3, 4, 5, 6 months, you're okay if they're asymptomatic. And so this is what the tables kind of looked like before, and how you would have to, and still do, have to look up the age and the height and, find that 95th percentile based on age and height and sex, right? So this is a girl who is 2 years of age and at the 50th percentile for height. So hypertension is 105/63 for her. If you don't have this, this is a really great app, the MedCalc app, and I use this all the time. It has a blood pressure calculator that was generated by the Hypertension Task Force, so it's reliable. And it actually, when you enter the age, the sex, the height, and the measured pressure, so this isn't one where you're looking up what the 95th would be. This is one where you're entering what their pressure actually is. And then it'll spit back at you a designation and give you a recommendation for how to follow it. So it goes a little bit further. There's a pediatric blood pressure app out there that was written by the husband of a pediatric nephrologist before the new guidelines. It's also a pretty useful way to look at this. But most offices nowadays have these charts, and your nurses will typically look this up for you and kind of put in what the 95th percentile is. The simplified table I mentioned is this. They wanted to come up with a highly sensitive way to screen kids for hypertension. This is going to overcall it because this uses the 90th percentile, but it's a lot easier for nurses to just look at age and sex and kind of have a loose screen saying, oh, this is elevated, I need to recheck this, okay? And that's in that guideline as well. So it's based on the 90th percentile for age and the shortest height. So again, it's going to overestimate the diagnosis a little bit, but it's a good sensitive screening tool with a high negative predictive value and a little easier to navigate than the busier charts. All right, next key action statement. A diagnosis of hypertension is made in a child when the blood pressure is at or above the 95th percentile on 3 different visits by trained healthcare professional. So that's not the 2 additional readings that are averaged. Once you do that and you assess the kid as having stage 1, then you bring them back to a couple other visits. Again, assuming it's stage 1, assuming they're asymptomatic, before you pass judgment, because maybe they were anxious that day or whatever. Okay, and again, if initial is elevated, you do your 2 additional ones by manual checks. All right, so this brings in again some of the older part of the talk, looking at the etiology. And so when we go see a kid for the first time referred to us for hypertension, we go in the room to use our history and our physical to help determine whether we're suspicious of secondary or we think it's essential. So there is no test for that, right? It's a kind of a clinical assessment. And in a school-age kid, you kind of go in there assuming it's essential. And you need something in the history and something in the physical to talk you out of that, to make you want to pursue. We get kids referred to us all the time that have had mega workups that were unnecessary, okay? So what is essential disease? That means there is no underlying cause. It's in part genetic and in part environmental. Typically 6 and above, but 6 and above. So 1st grade and up, you know, most likely you're talking about essential hypertension anymore. You know, we could argue a little bit about the non-overweight 6 to 10-year-old, and you'll see that in a second. Typically going to have a positive family history, but doesn't always. Is very closely related to BMI, but frankly, so is secondary disease. It's made worse by obesity. You're going to have a negative birth history, no history of urinary tract infections, no history of acute kidney injury, nothing to make you suspicious, a negative history. A little bit more stress sensitive, typically less severe, and can be systolic only, but those are loose kind of things, so you can't really hang your hat on it. Secondary disease percolates higher if you're under 6. You have a lack of comorbidities like obesity. You have a very boring family history. You're more likely to have more severe hypertension with secondary, so symptoms are more common. And diastolic hypertension is typical for secondary disease. But again, that's just a loose association. So again, all history and physical things that you can develop that gestalt of whether you suspect secondary disease or not. And if you suspect it, then you pursue it. So this picture has been all over the place, but you know, I don't have to convince this audience of the impact of obesity on the health of our kids, but this is obviously a tremendous impact on the incidence of hypertension. And this relationship between weight and blood pressure begins very, very early on. We are now in our office seeing 3-4-year-olds with obesity-related essential hypertension. Now, we've ruled out everything else in those kids because of their age, but that's what they end up having. So it's really mind-boggling how common this is becoming. So obesity in itself, as you know, is a risk factor for cardiovascular and other diseases. So these kids have a lot of morbidity brewing in them. One thing that I like to show you is that, you know, obesity is associated with insulin resistance, right, or hyperinsulinemia. And if you look at insulin, or what I refer to as the perils of insulin, I know you got to have insulin, but it activates your sympathetic nervous system. It alters your vascular reactivity. It causes sodium retention in the kidney. and it activates your renin, angiotensin, aldosterone axis. So insulin is a risk factor for hypertension, and there's one of the links there between then obesity and hypertension via hyperinsulinemia. So what hasn't changed over the years is that far and away the most common cause of secondary hypertension in kids is renal, okay? That has not changed. But what many people don't realize, especially the medical students that come through, and I ask them to give me a kidney-related cause of hypertension, 9 out of 10 of them say renal artery stenosis. And we've got 3 of those kids in our whole practice. So that is our zebra. The good news is it's renal parenchymal disease in the vast majority of cases. So if you're ever on the fence about convincing yourself the kid has essential disease versus secondary, just get a renal ultrasound and you've ruled out 80% of secondary causes, okay? So a very non-invasive, easy to order test to screen for cystic disease or scarring or obstructive uropathy, dysplasia, hypoplasia, things like that. Do we see renovascular disease? Yes, we see it in neonates and infants. We see it in syndromic forms. We, again, have the occasional adolescent female with fibromuscular dysplasia. We have our share of neurocutaneous disorders that have renovascular hypertension, but again, it is the exception. Coarctation, if you're dealing with an infant toddler, obviously you want to be mindful of 4 extremity pressures and pulses. And then the endocrine causes, if you ever diagnose a pheochromocytoma, you deserve $1,000 because that is like a once in a lifetime diagnosis. Very, very rare, worked up way more than we get confirmation of that disease. So that is extremely rare. By the way, the most common unnecessary test in the community is thyroid functions. And hypo and hyperthyroidism are associated with hypertension due to their impact on sympathetic nervous system. You don't need to screen thyroid unless there's a symptom, a finding, okay, or a family history that's compelling. So it is not a routine part of the workup for hypertension, but it's the most commonly done blood test outside of chemistry panel. Neurologic causes, you're going to be aware of these drugs. I think, as we'll see in the history in a second, going through that, over-the-counter drugs, illicit drugs, any stimulants, things that can promote elevated blood pressure, just smoking, right? I mean, and you know this, adolescents especially, you got to ask these questions without the parent in the room. So the causes vary by age. So you'll see an evolution here from the neonate that's more likely to have renovascular disease. You know, the NICU baby with umbilical catheters is going to get thromboembolic complications that are going to result in renin-mediated hypertension, congenital uropathy, coarc, so truly secondary, right? And then when you start getting out of the infant period into toddlers and preschoolers, that's when renal parenchymal disease tops the chart. Now that's also when essential starts to appear. And, you know, it's last on this list, but stay tuned, right? It's climbing the ladder in younger and younger kids. So the pre-adolescent parenchymal disease and essential hypertension are tied. So again, in that age, you don't have to do a renal ultrasound unless you have a suspicion, okay? And then obviously adolescents, far and away, essential hypertension is the most common cause. This is an interesting bar graph just showing you the evolution of primary versus secondary hypertension and how it's done a complete about face since the 1980s. I was not in practice in the 1980s, by the way, just so you know. But look at the difference between the prevalence of primary disease now versus back then. And this is in large part due to the obesity epidemic and worsening lifestyles, etc. I'm not going to take you guys down a genetic rabbit hole today, but I think it's important to remember that things classified as essential hypertension because of a family history sometimes are monogeneic forms of hypertension, and we know this through advances in positional cloning and identifying certain genes that lead to specific abnormalities in the kidney or other areas that support hypertension. the common thread amongst these conditions is that they're going to have potassium abnormalities. And so, you know, every kid that you diagnose with hypertension is going to get at least a one-time chem panel, right, to check, of course, their creatinine, but also to look at their electrolytes. So kind of an interesting read. One of Stalwart's favorite diagnoses is Lytle syndrome because it's receptor gone wild. He loves that. But just be aware of these. And I'll tell you the classic story is when you really start questioning the parent who has hypertension, and they'll say, oh yeah, they could never get my blood pressure under control, and they finally put me on this amiloride, you know, water pill. And you go, aha, okay, now we're on to something. And you can get genetic testing for this, but typically going to be hypokalemic with one exception, and also typically going to be on the alkalotic side. So hypokalemia, alkalosis, even subtly in a kid with difficult to control hypertension, one should think about these things. All right, so what do? Consider the following questions. Is it real? Okay, that's a tough one. That first hurdle is the kid anxious, were they cooperative, et cetera? Was the cuff the right size, and is it sustained? Is there a definable cause? Again, school-age kids, most likely not, but you trust your history and your physical. Are there other risk factors? Because we know hypertension is one, so do we need to look at them as hyperlipidemia, prediabetes, et cetera? And everything starts with a good thorough history, and I'm not going to bore you with this except to say that birth history, even in an obese 17-year-old, is vital for this, as well as a history of urinary tract infections. And I'll tell you, you have to ask this a few different ways. I had a young lady in my office with stage 2 hypertension that said no, she had never had a UTI her whole life, and her mom confirmed that. And then we couldn't get the blood pressure under control, and she had a little proteinuria, and they said, oh, well, yeah, she had 3 kidney infections. You didn't ask me about that. So I now say, have you ever had a bladder or kidney or urinary tract infection, so that you can be sure that that history is indeed negative. Sleep disturbances, nutrition, physical activity, very important. Growth and development. Remember, a short, heavy kid should raise some red flags to you for something syndromic or thyroid or other things. But you guys do this all the time. This is where, speaking of the family history for a second, you have to take off your pediatric hat and become an internist, right? Because it's very important to know the cardiovascular history in the family. So strokes, heart attacks, cholesterol, diabetes, kidney disease, hypertension. So even in our world, most of our family histories are very renal focused, except for hypertension. And that may push you to treat earlier just by stratifying risk based on family history of cardiovascular disease. You really can't rely on symptoms in kids unless they have malignant stage 2 hypertension. But this study looked at before and after treatment, and 3 symptoms: headache, difficulty sleeping, and daytime tiredness, which is probably tied to difficulty sleeping. And those got statistically significantly better after treatment. So the problem with headaches, right? How many kids have headaches? And headaches and blood pressure very much become a chicken and egg problem. So if you take your blood pressure while you have a headache, it's going to be above its baseline from the stress and pain of the headache. So in fact, we have families that monitor at home because they want to, and they'll call us up and, you know, Susie had a headache and her blood pressure was 140 over 90. Well, okay, well, you know, it's probably the headache and stress and so forth. So true headaches from malignant hypertension, you need a really good number up there to connect those dots. So we have a lot of kids as we're seeing them, and they'll say, I'm still having headaches, and their blood pressure is 120s over 70s, and we go, you need to talk to your pediatrician about that. Okay. Again, medications, even over-the-counter stuff, because stimulants and decongestants and so forth can elevate your blood pressure. So review all this with every patient that you see. Physical exam, growth and BMI, looking at other vitals, any dysmorphic features. We are all lousy at identifying fundoscopic changes, right? We don't do a lot of eye exams. We also don't have the fancy equipment and dilated pupils that ophthalmologists have. I can tell you that, you know, eye findings with hypertension in kids are incredibly rare. So, you know, you don't need to worry too much about that. Skin, however, is the most forgotten organ system when it comes to assessing a kid with hypertension. So, you know, if you don't go looking for those vasculitic lesions or neurocutaneous lesions, you may miss them. So at that initial visit where blood pressure is a concern, it's a good idea to do a very thorough skin exam. All right, what do we do with them? Well, it's pretty simple. So every single kid with diagnosis of hypertension, okay, after you've gone through the litany of repeated pressures and they're hitting that 95th percentile, they're going to get a one-time chem panel. They're going to get a urine screen, very simple, probably getting the urine at their annual physical anyway. And then they're going to get a lipid profile, okay, and they may have already gotten that as well. If they are deemed at risk, they're going to get an A1C. So if they have obesity / acanthosis / family history of diabetes. Now that has nothing to do with the etiology of hypertension or how you're going to treat it. But again, we're expanding that cardiovascular risk net that we're casting out for those kids. The renal ultrasound, you know, again, you've got a great non-invasive, painless, no radiation, reasonably expensive imaging study for kids to rule out the most common cause of secondary hypertension, but do not do it in every adolescent who's obese that you think has essential disease. So if they're young, if they're under 6, okay, if they have a history to compel you, like UTIs or prematurity, if when you check their urine, they have hematuria or proteinuria, or when you get their chemistry panel back, they have an elevated creatinine, get the renal ultrasound, okay? If you go see, for example, a 10-year-old male who has a BMI of 20, who has one great-grandparent with hypertension, and he's just not looking like the poster kid to you for essential hypertension, and you choose to get the renal ultrasound, it's going to be normal, but it is not wrong, okay? Again, it's a non-invasive, easy, painless. Echocardiography is, as the pendulum has been swinging wildly on who gets an echo, and I put this in there because the latest guideline that we're talking about recommends that any kid that you decide to pull the trigger on medication should have an echo. But in full disclosure, I'll tell you, Dr. Kramer and I don't do that. So we find that they're coming back normal. So we kind of pick and choose who gets an echo, but just be aware that that's now the recommendation. And in truth, left ventricular hypertrophy is the most common end organ effect of hypertension in kids. Phase 2, you might get to, you might not, okay? But if things are you know, stage 2 hypertension, you find an abnormality in your first approach at the workup and so forth and so on, you might move on to these things. Renins and aldosterone levels are terribly confusing and not helpful. So where we use them is if you have abnormal electrolytes that compel you, and that would be, again, that hypokalemic alkalosis. And if you're young, if you're an infant or toddler, okay, then we will get those as a baseline. Remember that if you're on the fence about it and it's an appropriate patient to check at, and you're going to treat them by vasodilating them, it is good to get it before they get medication, right? Because if you or I get vasodilated, our renin and aldos go up. So they lose their accuracy once you start them on antihypertensive. All right, cardiac diagnostics. So again, the prevalence of left ventricular hypertrophy is 30 to 40%. So that's a lot of kids, and I don't know about that, but that's what the statistics tell us. And LVH is definitely associated with bad cardiac outcomes. Do not ever do EKGs in hypertensive kids. They're useless, okay? We get a lot of kids referred to us that have had an EKG. They'll miss LVH and they'll overcall it. So if you're worried, get the echo. Now, we finally got our cardiologists to, no, our cardiologists, that sounded bad. Our cardiologists are amazing. But the guideline wants us to look at left ventricular thickness in terms of gram per meter squared. And sometimes the left ventricular wall subjectively looks normal. And so a cardiologist will read that echo as a normal echo, but the left ventricular mass is elevated for age, okay, or for size. So you'll see now in all echo reports, this grams per BSA per meter squared for girls and boys, and 115 and 95 are the male and female cutoffs, okay? So just keep that in mind, that that is how we define left ventricular mass increases. All right, how am I doing? Children greater than or equal to 6 with hypertension do not require much of an evaluation for secondary causes if they have a positive family history, they're overweight or obese, lack of physical exam findings suggestive of secondary disease. So the workup is pretty straightforward. The therapeutic plan, non-drug therapy for everyone. The biggest frustration in the entire hypertension management scheme, or any kid that's obese, as you guys know, is good for everybody. It's multifaceted. And then the drugs. The drugs are really not to be feared. The primary reason that we will always get hypertension referred to us is the pediatrician's fear of the drugs. And it's appropriate, and you don't prescribe them very often, you're unsure, but it's not rocket science. You know, I always tell the residents that rotate with us, and after 4 weeks, you're like, oh, this is easy. And then 6 months later, you're like, oh, I don't know anymore. So, you know, it's easy for us to say because we do it every day. And we'll talk about medications a little bit. The goal of therapy is to reduce the bad outcome and reduce the risk of hypertension and cardiovascular disease in adulthood. But we want to get the optimal control. We don't want to be settling for mild hyper. Hey, we took you from stage 2 to stage 1. That's not good enough. So we strive to reach normal blood pressures. And then the non-pharmacologic therapy you are all very much aware of. It is what you practice every day at CHOC when you have obese kids coming in and you're counseling them, with the specific thing also being sodium, right? And that may or may not be covered in a non-hypertensive obese kid. So the salt story. Ideally, you want them down to 1.5 grams a day. The average South Carolina teenager consumes 6 to 8 grams of sodium in a daily diet, okay? So this is not easy. And I always tell the kids, hey, that sounds like a big number, but if you're average, here's what you're currently taking in. So it is a big, big change. Between us in this room and computer, not every kid is salt sensitive, but we don't tell them that, right? Because it's a healthier diet in general. And honestly, we don't know who's going to be and who's not going. So you've all heard about the DASH diet. It's come through the adult literature, the dietary approaches to stop hypertension. We have a handout on this. When I give it to the kids, I say, this is not the DASH diet, this is the oh-duh diet, because everything they're about to read in that, they're gonna be, yeah, I know that's good for me. I mean, the kids all know what's healthy, right? They're just not practicing it. Avoid caffeine is controversial, okay? So caffeine in moderation does not impact hypertension. But as y'all know, a lot of these kids are drinking these, you know, Red Bulls and other super caffeinated drinks out there. And it's good to get them off those because you're also cutting out sugar by doing that. So just, you know, it's worth reviewing with them what their caffeine intake is. Dietary cholesterol and fat when appropriate, glycemic load foods when appropriate. And the salt dilemma, it is incredibly difficult for families that, even those invested in making changes at home because they can't control what their teens are doing outside the home. People don't understand, we say, oh, just look at the label and give them guidelines and remember literacy, and maybe they don't understand how to read nutritional labels, coming up with healthy snacks, limited resources. But salt is very, very important. And, fast food is not just fast. It's cheap, convenient, and there isn't really good portion control. And as we push kids towards Subway, because it's, quote, healthier, remember how salty that is. So, you can see how you could almost reach your 24-hour sodium limit with one meal, right? I'll tell you just sort of anecdotally, the way to approach this is just to start chiseling, right? It's like, hey, you love your ramen noodles, okay, use half the pack, You love your French fries. Okay, order them without salt. McDonald's got to make you a fresh batch. And as you dip that saltless fry in ketchup, you're not going to notice the difference, and you just cut the salt in half. I mean, you just start picking your battles and try to kind of, whittle that down as best you can. There's a theoretic benefit of the other salts. This is part of the DASH diet, and why Mrs. Dash as a salt substitute is reasonable, because potassium has some theoretic benefit to blood pressure, as does magnesium and calcium. Exercise, especially with COVID, right? How many kids have you seen that have gained weight? It's because they can't go outside. Well, yes, you can. But we have a whole generation of heavy kids with strong thumbs, right? And this is a big battle, but exercise has an independent beneficial effect on blood pressure. It lowers sympathetic tone and vascular resistance. So aside from its contribution to weight loss, its directly influence on lowering blood pressure is important. It lowers insulin levels. So 30 to 60 minutes of moderate to strenuous activity a day. The guideline says less than that, but we push daily in the hope that you'll do it 3 or 4 times a week. And for most kids with hypertension, it is perfectly okay to play, and I'll show you some of that on the athlete here in a second. So at the time of the diagnosis of elevated blood pressure, advice should be provided on the DASH diet and recommendations for moderate physical activity. Again, according to the guideline, at least 3 to 5 days per week. Shoot for the stars, and you'll get a little less than that, right? But the more exercise they get, the better off they'll be. So when we decide who gets drugs and who doesn't, or when we pull the trigger, we kind of look at stratifying risk. And this is what internal medicine docs have done for years, right? If you are high risk, we're going to start medication on you sooner than if you are low risk. And what determines risk is the family history, obesity, and its complications. Target organ disease is easy. If you've got left ventricular mass increase, you're going on drug day 1, okay? If you end up getting that echo for whatever reason, it's abnormal and you haven't started medication yet, now's the time, because that's how you're gonna reverse that. Proteinuria, microalbuminuria, remember that the big 3 target organs, heart, eyes, kidneys for blood pressure, other than having a super malignant acute kidney injury from hypertension, we do not see hypertensive nephropathy in kids, okay? We screen urines, but if we find proteinuria or microalbuminuria, we're thinking more in terms of you have a renal cause of the hypertension, not you have hypertensive renal disease, if that makes sense. All right, so pharmacologic treatment plan, indications to prescribe. So stage 1 hypertension that has failed lifestyle change. Now this is very subjective, because has the kid done it and lost a little weight and their blood pressure hasn't budged? Or have they not done it and they come in telling you they did everything you asked them to do, but they've gained 20 pounds, right? We see this all the time. So this is a little soft, and you just have to look at, again, reviewing for symptoms and where is the blood pressure. If it's still low stage 1 and the kid says, I'm sorry, I just COVID this and I didn't do it, but I'm ready, I'm committed, and you want to extend that out a little bit, that is okay. But the guideline gives you a 3 to 6 month easy period of time for that. If they hit stage 2, they start drug day 1. Okay, so height of blood pressure matters. They're not going to have symptomatic hypertension unless they're stage 2. Okay, so that's a little redundant. If you end up getting an echo and they have left ventricular mass increase, they're going on drug. And if they have other significant comorbidities, your threshold to prescribe goes down. Chronic kidney disease, because even stage 1 hypertension in our world leads to more rapid progression of that chronic kidney disease. So we're going to treat you right off. All right, what do we use? In kids, it's a tie between ACE inhibitors and calcium channel blockers. Okay, in the adult world, you dilly-dally around with hydrochlorothiazide, and then you may add a beta blocker. We don't do that in kids. Okay, we use diuretics, but if you could just remember 2 drugs, I'll show you a table in a second, then you can treat any kid with hypertension. Okay, we're going to just zip through this. You know how they work and what the potential side effects. But the ACE inhibitors are the prils. I will tell you that lisinopril is our favorite over enalapril because it has a longer half-life and you dose it once a day. Enalapril, sometimes you have to add a second dose and compliance goes down because of that. You have to be mindful of pregnancy, okay? In an adolescent female, they need to be counseled. And you know, a lot of people ask me, do you use it in African Americans? Yes, all the time. And yeah, they can have a genetic allelic variant that makes them resistant to it, but you'll figure that out, okay? But they're highly effective in African American patients as well. Calcium channel blockers dilate by blocking the influx of calcium. Very well tolerated. Amlodipine is our favorite pediatric drug because it's wimpy and has practically zero side effects and can be dosed in babies in the NICU. So do not fear amlodipine as long as you follow weight-based dosing, and I'll show that to you in a second. Diuretics, we use hydrochlorothiazide as a second-line drug to augment the effect of our first drug. We don't typically start hydrochlorothiazide as monotherapy. Angiotensin receptor blockers, they're the newer in vogue class of medication. I will tell you that there is absolutely zero benefit of an ARB over an ACE unless you've had cough or angioedema, okay? It is okay to use them. They're more expensive. They're equally effective, so they're not wrong, but there's no benefit over ACE inhibitors. Beta blockers, we tend not to use because they have side effects and kids won't take them. Clonidine, kids come to us on clonidine with their ADHD at bedtime, and that's having no impact on their blood pressure. Remember, clonidine has a very short half-life, so if they take it at bedtime, it's gone by 3 a.m. All right, so here's something to remember. Look at this. So amlodipine and lisinopril are two most commonly prescribed drugs. Both have a starting dose of 0.1 per kilo with a max of 5. Both can be used just once a day. Amlodipine, you'll see the indication is daily. I should take out the BID because we do that, but it's not pharmacy recommended. Both come in a 1-to-1 suspension, and both come in similar tablet strengths, okay? The only thing about ACE inhibitors is you do have to monitor renal function. We're very neurotic in pediatrics, so we check a chemistry panel a couple weeks after starting and twice a year if we're not changing the dose. If you're an adult and you go on an ACE inhibitor, they probably go years without checking the renal function. So we admit that's pediatric neurosis, but that's what we do. All right, so a good strategy, if you need to start a kid prior to the workup being complete and want the safest drug known to man, grab amlodipine, okay? Anybody with proteinuria, renal disease, diabetes, or somebody you suspect renovascular hypertension, you're gonna go right to an ACE inhibitor. And we use a lot of ACE inhibitors even in our basic obese essential disease patients. And if you get some response to either drug, but not all the way, now comes the hydrochlorothiazide to augment the effect of the first drug. A lot of these come in combinations, so once you get to where you need to go, you can switch them at times depending on dosages to a 1 pill once a day regimen. So calcium channel blockers are safe. Don't fear the ACEs. Diuretics have made a comeback but are augmentative therapy only, and beta blockers have side effects, okay? So in monitoring, if you prescribe medication, you want to see them back in 4 to 6 weeks, be sure they're taking it, see if it's working. This is the biggest problem, right? Blood pressure is not normal yet. Are they missing doses? All right, let me tell you about amlodipine. You miss 1 day, it takes 2 to 3 to build back up in your system. A lot of kids come in and they'll say, oh, I'm only missing 2 a week. Well, you might as well not even be taking it, okay? So you must be Mary Poppins perfect when it comes to blood pressure medication. And that has to be assessed at every visit, of course. All right, as far as the athlete is concerned, most of them are allowed to participate and play, and the risk of having a sudden cardiac death from hypertension are slim to none. So you take your family history. The evidence is conflicting in some studies, but the guideline says let them play, okay? You do not have to. Now, there is an exception to that. Stage 2 hypertension, you're going to get control first, okay? And particularly if they have left ventricular hypertrophy, even with stage 1, you're going to get control first. But that's easy to do if they'll be compliant with their medication. We don't like to keep them off the field or off the court because that helps their blood pressure, right? The one thing that I most commonly limit is weightlifting, because that static activity really results in a high, that Valsalva, right? To be honest, I don't know that there's ever been a report of somebody dying on the bench with hypertension. But weightlifting is very important to kids, right? So it is a good tool in your toolbox to say, hey, you take this medicine every day, and in a few weeks you'll get your pressure down. I'll let you go right back into the weight like I have control, but they think we do, right? So it's a good carrot to dangle in for particularly football players who want to get in the weight room. All right. This is something I already told you. So you may assess for target organ, and you need to be below stage 2 cutoffs. Okay. All right. This is an ambulatory blood pressure monitor, and we'll wrap up. This is what it looks like when the kids comply with it. Okay. So each vertical line is a blood pressure. The horizontal lines are the set norms for systolic and diastolic. And you'll see with the black line, that's sleep. And the norms dip, right? Because we expect you to dip with sleep. So the classic story is a kid with elevated office readings. We do an ambulatory monitor and we prove they have white coat hypertension, okay? So we have 3 of these devices. We're doing them all the time. And as you guys work through the clinic, you'll know that you can refer kids just for the monitor. If you don't think they necessarily need to see us, we're cool with that. We'll do this, get you the report back with some guidelines in the report on how to manage it. But the results here track much better than random office readings. Of course, it eliminates the concern of white coat hypertension. You get to look at nocturnal dipping. One of the early markers for essential disease is a blunted dip. And what we look at on this report is the blood pressure load. And the blood pressure load, and you'll see it in the results, is very simple. It's the percentage of the readings that were high, okay? You are allowed up to 25% of your blood pressures in a 24-hour period to be abnormal and be considered normal. 40% or greater is hypertension, okay? So just isolated spikes of blood pressure don't matter. It's the averages, it's the load that does. There's a fairly newly recognized thing known as masked hypertension. This scares me a little bit. I don't want to scare you, but this is the opposite of white coat hypertension. So kids with normal office readings who have very abnormal ambulatory blood pressure monitors, I don't know what to do about this, right? I mean, we're not going to do ambulatory blood pressure monitoring as part of routine well child care every year. But it is now in studies showing to have negative impacts down the road on cardiovascular health and so forth. So stay tuned. There'll be more literature, I'm sure, coming out on that. So ambulatory blood pressure monitoring should be performed for confirmation of hypertension for elevated blood pressure for 1 year or with stage 3 hypertension over 3 clinic visits. I've just regurgitated to you the guideline. The bottom line is if you're getting random elevations and want to know if they're real and want us to do that for you, just let us know. Suspected white coat is the most common. What we have learned is that kids with coarctation that get repair need to have this annually. And so you may have kids at CHOP that have had repaired coarct that seem to be doing well with normal office readings, but they are a high risk group for this masked hypertension and they already have underlying cardiovascular disease. So they should be getting this annually. And then kids with chronic kidney disease, it just helps us know we have that tight control that we need for those kids because of their risk of progression. Lots of apps out there. The bottom middle is another blood pressure app that again was pre-new guideline, but still fairly useful, quick and easy to use. Other apps for reminding kids to take their meds, dietary apps, all kinds of things out there as they're in their devices all the time. All right, so we talked about the 8 significant changes from the new practice guideline. And I think that's it. Sorry, that was rapid fire, just barely. So any questions? Live or otherwise?
Happy birthday, Dr. Holland.
Thank you. All right, guys. Thanks for listening.
Happy birthday. We're not, I don't think we're working. Well, that was awkward. I'll look in your ear.
Right here. Yeah. Yeah, that's fine. You weren't here. No, it's okay. It might be right there in the beginning. Did you start buzzing? Yeah, buzz in my ear. And I couldn't hold it, and on and up and down, my ear feels funny, you know?
Oh, yeah.
Right, so nothing in there? All right, good.
I'm like nervous.
Oh, I had her with him, because I felt like it was good. My ear was fine.
Yeah, and then she told me I did a bad job.
It was too, I was like,
I bet I had. I helped her.
Good practice. I went, yeah, no, they were